Welcome to the ACE Hot Topic webinar titled Improving Access to Genetic Counseling and Testing. I'm Jen Wood, Administrative and Meeting Manager for ACE. I have a few housekeeping items before we begin. First, if you have not done so already, please renew your membership to ACE as membership expired at the end of June. Please visit www.cancerexecutives.org for additional information. We hope you can join us for one or both of the upcoming events. First up is the International Oncology Leadership Conference being held November 17th to the 19th, 2019 in Antwerp, Belgium. Secondly, please join us for the 26th ACE Annual Meeting being held January 22nd to the 24th, 2020 in New Orleans. To find more information about both of these educational events, please visit the ACE website. The handouts for today's webinar can be found in the handout section of the GoToWebinar toolbar. We will also be posting them to the members only section of the ACE website after this presentation along with the recording. We will be holding all questions until the end of the webinar. So if you think of anything during the presentation, please submit your questions through the question box in the GoToWebinar toolbar. It gives me great pleasure to introduce today's webinar presenter, Nancy Harris. Nancy serves as the Vice President Oncology Service Line at Sharp Healthcare, a not-for-profit integrated healthcare system in San Diego, California. Sharp Healthcare includes 4 acute care hospitals, 3 specialty hospitals, 3 affiliated medical groups, and 3 outpatient cancer centers. Sharp Healthcare saw 4,500 new cancer cases in 2018 and provides care for over 30,000 unique patients per year for services related to cancer. Ms. Harris has led a number of cancer programs since 1990, spanning the rural Appalachian Mountains to the urban sprawl of Los Angeles. Among the organizations served were Sutter Health, Northeast Georgia Medical Center, St. Joseph Health System, John Wayne Cancer Institute, Providence Health and Services, and now Sharp Healthcare. Ms. Harris holds a master's in public administration and health services administration from the University of Southern California. She has been involved with development and oversight of cancer genetic programs since 2004 and was president of ACE from 1999 to 2000. Again, it gives me great pleasure to introduce Nancy Harris, and please take it away, Nancy.
Thanks very much, Jen. Good morning, everyone. I'm very happy to be here and share this information, and I hope that you find it useful. To begin with, as far as improving access to genetic counseling and testing, we know that this is a hot topic because it is scarce resources, and trying to manage this very unique service is a big challenge for all of us. There we go. Genetic counseling challenges. There are many of them. It's the fast pace of the genetic discoveries, it's changing guidelines. We know it's challenging for our clinicians to keep pace, and most importantly, or not most importantly, but perhaps most challenging, is the insurance coverage and copay dilemmas that we have. To give you an idea, I just went back a couple of years to 2016, and this is what we saw from NCCN as far as their summary of the concerns as far as breast and ovarian hereditary risk. Well, in 2019, we're already on version 3 and have been for quite some time this year of guidelines, and you can see these are now the breast and ovarian hereditary risk guidelines. So it is challenging to keep up. Jen gave a great overview in terms of just the introduction as far as some things with Sharp, but I also pulled out, here are some of the cancers that we see that are most likely to be ones referred for our cancer genetics program, and that includes breast, colorectal cancer, pancreas, ovarian, our high-risk breast, and when I use that term, and I'll use that throughout the presentation, it's really those patients diagnosed at less than or equal to age 50 and or they're triple negative. We have counseling services at 2 of our 3 centers, and then we also support the tumor boards across the system, ones that are likely to have some questions about genetics involved with the care and management of patients. We began the program back in 2009 before I was at Sharp, and it was really a consult program that was very minimal as far as a consultation service with a 0.2 FTE. I came to Sharp in 2015 and we started focusing on some program growth. However, the baseline that we started from is that we were scheduling appointments in Outlook. Okay, so that's not great. Referrals, we even got referrals on the back of business cards from our physicians. There was no EMR documentation. Our reports were done in Word, no templates. We were offering services at a single cancer center and we had 0.8 FTEs of a genetic counselor. Our 0.2 went up to a 0.8. As we look back at our statistics, we started seeing a big growth, of course, in referrals and consults as we started gearing up the program, creating greater awareness. But one of the things that was a huge dilemma for us is that we were still not seeing 48% of our patients. And so that's an access issue, or it may be a process issue. So we needed to delve into that further. So we looked at additional strategies to address this access issue, and our perception was it was access. One of the first things that we did is we designed a referral form that contained all the information needed to move the patient through the insurance process, but also it served as a cheat sheet with criteria for clinicians to know appropriate referrals or prompt them as far as appropriate referrals. And we went through many iterations as far as this referral form. Then we found as we had some high volume refers, so what we did is made it into an editable PDF form where they could edit the check boxes for the criteria and they could fill in the insurance information but not change the criteria. We also developed some relationships with very knowledgeable nurses and allied health professionals in high volume practices so that they could serve as the initial source of referrals, reviewing that to make sure that the criteria were met and they were appropriate for referral. And of course, we developed relationships with our physicians and the practices in developing trust so that we made sure that they trusted in our recommendations, and that evolved over time. The second thing that we knew we needed to do was look at staffing. In many of the genetics programs that I've had, one of the key features is having a high-performing administrative assistant, that admin support team, to really help facilitate and offload a number of tasks that are not needed to be done by genetics counselors so that you can optimize use of their time for patient counseling and queries related to mutations in VUSs. So finding that right person, and sometimes you have to dig deep to find that right person, but they must be very organized. I've included some information as far as the tasks that they do so that that may help you as you're contemplating looking at staffing for your program. We also added an additional administrative support person, and they really do a little bit less as far as complexity of tasks, but they've got general phone contact. They're organizing a lot of the referrals so that they can be reviewed, assessed, and entered. And then if we get referral forms that are not complete, they help us get the missing information. We've also reached out to some programs surrounding us that have some genetic students that they would like to add some additional experience from inside the actual practice. And so we've got 2 students currently that are either doing summer work or doing course that can work with us over the course of the year, depending upon their study time. And then also we had both of our counselors increase their 0.5 status to a 0.6, which has helped a little bit, but there's more to do. The next thing that we tried was process improvement. So we really diagrammed the process looking at the roles, responsibilities by the personnel, and then we looked for opportunities to reduce step or combine activities. So one example is we found that when our patient access services individuals were calling to verify insurance, they could also, in addition, ask for what is the appropriate process and who do they need to connect with should testing be required and another authorization. This offloads the department from having to get that information later down the road and a potential delay in terms of getting the patient authorized for testing. We also collaborated with managed care, and these are really the medical groups that manage a lot of the authorization process that goes on for genetic counseling. And in San Diego, we have such a high penetration of managed care that we don't go anywhere without an authorization. We can't do anything without an authorization. And so many of our patients are under HMOs that is just the norm. So we're very attuned to that. So we collaborated with them to reduce the amount of authorizations because of that trust level built. And they also gave us access to the authorization portal so that we could generate a request, but we could also see immediately when that authorization request was approved. And then, as I said, that trust that we gained through doing some pilots and working with them and demonstrating results really made a difference in terms of reducing the amount of back and forth that has gone on. We also expanded the geographic sites and added another counseling site to our program at a second center. That meant we needed to secure assistance for office space, receiving patients, and then just support that we needed for results delivery for patients that wanted snail mail results rather than by email. When we are at the sites, we actually support the program through tumor board participation so that we're there to interact with the physicians and the staff if they have curbside consults, if they have questions, and of course review the cases presented at tumor board. And again, the all-important cultivation of the physician and staff relationships. The fifth thing that we did was we looked at our genetic-specific software support, and we knew that there were tools out there that could help us in terms of many of the different tasks that are required for a full genetics consult and review. So in our first round of looking at genetic software, we did not find a number of programs in our searches. We did end up with two prominent software programs, and one was a homegrown product and the other was a national product. We elected to take the national product. We felt that it would have sustainability in terms of longevity. Sometimes the homegrown versions kind of die out, and we wanted to make sure that we had frequent updates with all the changes going on in genetics, and that we could automate a number of tasks that you'll see later. We implemented that product and realized fairly quickly that it was really not delivering what we expected. It wasn't helping us reduce the amount of time we expected, and the consistency as far as uptime was not there that we were looking for. So there was a lot of frustration. We went back out and we looked again, and lo and behold, there were new software products. And the one that rose to the top pretty quickly was Cancer IQ. And I mentioned that just because there's more and more programs out there, and you really need to start assessing in a much more rigorous fashion now as far as the differences between different products. We looked at and developed a spreadsheet of 61 different operational functionality and support elements that we wanted to rate any product that we were going to. And we rated the product that we were currently on against Cancer IQ to see what the differences are, and would there be enough to switch out after only a year. There were quite a few obvious differences as far as improved features in Cancer IQ. So we went forward with that. What that meant is then we needed to take that to our information technology to see how this new product would interact within our system. And then we had a new committee that we needed to go forward with, and that was our consumer-facing technology committee, where any product that interacts directly with patients or the community needs to be reviewed for the features and make sure that it doesn't conflict with another customer-facing technology that we have, and that it's consumer-friendly and simple, such as single sign-on for the individual that's completing things. Also, when we do a new IT project at Sharp, we need to do a project plan, and we need to state goals. Our goals for this product and what it would help us achieve are standardization of our consultation reports, our results and recommendation reports, so that we're always putting in the same information, and the expectation of the physician and the patient is consistent in terms of what they would get as far as information back, results back. We certainly wanted to reduce the genetic counselor time spent in the pre-visit and report preparation. That's one area where we felt we could reduce that time so we could see more patients. And indeed, the third thing that we were looking at were increasing the number of patient consults seen. As we do these projects, we actually come back and measure against our initial goals to see if we've achieved what we've set out to do. Some of the things that we looked at as far as driving efficiencies in the program were the completion of a family health questionnaire, and it was important to us to have a number of options in doing so. So we wanted to be able to send out the request or the information using a family health questionnaire that is sent out to them by email. But we also realized not everyone has a computer, and so we wanted to make sure that there was access by tablet. They could come in early and complete the questionnaire on the tablet prior to their visit. And we have a significant portion of our population that is Spanish speaking only, so we need to have things in English as well as Spanish to really serve our patients. For patient communication, we do emails and a variety of things that are auto-generated. And then for provider communication, we're communicating with them in a standard way as far as patient contact attempts. You know, if we've made 3 attempts and not able to serve the patients, then, or find the patients, or get a response from them, we actually need to enlist the support of the physicians. We also created report templates, and that was for both patients and providers, so that we were consistent in the information that we were providing, our results and our recommendations, and that we also incorporated the use of smart text so that we could hyperlink in established definitions for results, care management, and various terms that we have for use in genetics. So this is what the experience was that we had with Cancer IQ after we implemented. And it really supported a lot of our goals for access, quality, and the efficiencies we were searching for. So here are a few of them. You know, the tablet and everything worked. I will tell you that lessons learned, check your Wi-Fi in all areas. One of our consultation offices is right next to the radiology department with all their lead shielding, and so we had to get additional Wi-Fi capability in order to make sure that that works smoothly. We did find that the auto-generated patient reminders were great, and they helped a lot in terms of reminding patients. It doesn't eliminate the need for the interpersonal connections and reminders, but it does help. And then we also looked at the fact that when the patient completes the FHQ with the information, it actually generates or goes into automatically running the risk models that are appropriate, as well as generating a pedigree. One of the things we were looking for in the software is the ability to edit the the pedigree very quickly while we're speaking with the patient, because oftentimes what happens is they submit information, but then further conversations with relatives or in the conversation with a genetic counselor, they identify additional risks or individuals involved in their family that have had risks. One of the more common ones, believe it or not, is the fact that if we have an affected patient, they forget to reveal the fact that, or put into the risk model, that they've got cancer and putting them at risk. So they're thinking about the whole family, but they forget about themselves. So oftentimes we have to make edits so that we have a complete record as far as the pedigree. If we get to testing, then it also helps us by auto-populating a lot of the information from the patient into the test request forms so that that can offload some of the paperwork and going to the labs that we use for testing. And then one of the things that we looked for in our second product was really the use of evidence-based medicine in testing criteria as well as in care management guidelines. And that was a unique feature for Cancer IQ, is really taking all this information. So what does it mean for the patient? What does it mean for the physician? And that's really, what is the impact of care management? So Cancer IQ also helped us in terms of looking at our processes and helping us find solutions to the various procedures and processes, and they were also working to improve their process of the software and the steps taken. We love our weekly reports that we get from Cancer IQ, looking at key things like number of patients seen, number of no-shows or reschedules. It looks at the number of patients that completed their FHQ online at home versus having to come in. And it gives us an idea as far as number of patients tested, percentage of patients tested, and the results as far as what impact did that have on care management. I think the other thing that we really valued that Cancer IQ provided was the fact that it has a mechanism to store our variants of unknown significance in the software by patients so that we can actually go back, and as more information is revealed about a VUS, whether it's benign or malignant, affecting patient care or not affecting patient care, we have the ability to go back to all of our patients that had that VUS and provide that updated information to them as well as their physician so that they know whether they need to make care management changes or they have something that they don't have to worry about any longer. Things that we're looking forward to in the future would be, we are on Cerner as our system-wide EMR, and we're looking at that plug-in opportunity as far as Cancer IQ, and that is in process. And that was one of the things that I really asked Cancer IQ to try and approach Cerner about that, but I also went to Cerner and said, can you look at this particular product and incorporate it so that we can have better integration of the product with our EMR? We also look forward to improvements in data tracking and management as we get to know the program more and more and improvements are made. I think that will be very helpful in terms of future streamlining and program management. And then we are in the process now of looking at electronic genetic counselor signature capability. It sounds like a very small step, but it actually is a huge difference when it comes to time saving. Instead of having to download a report, sign it, upload it, and then transfer it, it can be done all online at the time the report is generated, saving several steps. And every time you do a step, there's a potential for a miss, and then moving it along faster. One of the things that we truly enjoy about Cancer IQ is actually the working partnership that we have. It's very collaborative. They are very responsive, and they're continuously improving. In looking at some of the methodologies for streamlining and process improvement, I discovered a book by Jeff Sutherland called Scrum, The Way to Get twice the work done in half the time, which of course was very interesting to me. But there were several good features or suggestions. And when I found out that Cancer IQ was a scrum shop, and so they understood the principles of this, that was even more attractive. The inclusion of evidence-based medicine as far as in our product was really important, and I wanted to make sure that they kept up with the updates so that we always had a current product and we were always treating our patients with the best care. And so you'll see a whole variety of things incorporated into Cancer IQ that include breast cancer risk as far as criteria for the risk models. It looks at referral guidelines as far as risk, the testing guidelines, going to a number of organizations that have input as far as who should be tested and for what, and then also the NCCN care management guidelines. So once we get the results, okay, how do we incorporate that into the care of the patient going forward? One of the reports that Cancer IQ does that I absolutely love, and we just did a revision to this one, updating it, is the care management changes that by seeing and coming to counseling and having a risk assessment done, what did that do for our patient population? And you'll see we implemented with a go live on November 14th, 2017. So that's why 2017 is so tiny as far as those numbers. But then 2018, you'll see that there was quite a bit of growth as far as the number of impacted patients. Now I would call your attention to looking at the difference between 2018 and 2019 year to date. And this is within 2 weeks of this presentation. And you'll see that in many instances, our 2019 results to date outpass the full year of 2018. What that says to me is that we are seeing more of the right patients, getting them in, getting them consulted, and we're seeing more and more of the correct patients, appropriate referrals, as well as growth of the program. So here's a listing of the different reports and the contents that we get from Cancer IQ. And not only do we do weekly reports, we do calls, just huddles essentially for 30 minutes or less every 2 weeks on average. And then we do a quarterly administrative report where we go over the metrics, what are the product updates going on for Cancer IQ, and their goals for coming up, and the product request status. I love the product request status. I use this for all my IT projects. And what I do is I keep a log from the time of go live, and it's a running total. It includes all the different requests we've made of the company as far as improvements in terms of our own product or something that they offer in broad spectrum to all their clients. So since we did our go live, we have had 121 requests to date. They know pretty much whenever we have a call, there will be at least one new request. And the way that I track this is once a request has been completed, it's in green. If it's important but unable to be completed at the time, it turns to red. And then if it's gray, it's because the product has evolved and that request is no longer relevant because it's incorporated in the general offering of the product. Or something's changed as far as our practice and we no longer need it. So the bottom line is our strategic goals were achieved with this implementation. So as far as standardization, we have standardized communication and it actually continues to improve as we develop the standard language that we're pulling it from our references for a variety of the topics. We keep expanding that. And then also we've standardized some of our physician communication regarding patient status that they're not responsive, or we want to give them a quick result to be followed by a results and recommendations report, but we want to give them notification, particularly if we've got an affected patient that's making a treatment decision and wanting to get that information to them quickly. We significantly reduced the genetic counselor time spent in report generation. So for our productivity results, we looked at, we did some timing studies, and pre-implementation of Cancer IQ, our average time per patient that had both consultation report as well as a testing and then a results and recommendations was 4.5 hours. Our current prep time is 2.5 hours. So that's really a savings of 44.4% preparation per patient. That's substantial. And then we were able to increase the number of patients that we were seeing with that efficiency gain on our genetic counselors. So that meant 350 more patients could be seen with that savings. That's huge. So lessons learned. One of the things that we've learned is really you need to do a step-by-step diagram as far as all the steps, and that's to be used as far as a reference sheet as the counselors and the whole staff are getting used to using the software. It also serves as a training tool for new staff coming in as far as what the process is. By delineating this, you really get clarification of roles and responsibilities, and also you may identify further ways that you can reduce the number of steps by having it just spelled out. Another thing that we learned is that we need to standardize how everyone is using the product. So standard notation, so that when a call out has been done or a notification has been done as far as a result, that needs to appear in a standard way in the product and in a designated location so that everyone in the department knows where to go for that information. So as we get calls or queries or something changes with a patient or whatever, we all know exactly where that information is. By having standard notations, we can actually do searches within the database as far as our patients to see how many patients have a certain trait or have an issue or something like that, and that's helped us several times. We can also use the information for looking at report turnaround times to make sure that we're timely as far as notifications with results as well as reports from the time the patient was seen to the time the report is generated, so that we are a high-performing department with information, et cetera. We can also look at it for what were the wait times that patients had in terms of getting in to see a counselor. And it serves as great communication among team members as far as knowing where they can get the information and where it's at in the record very quickly. The other thing that we found is that we need to routinely review steps in the process to ensure everyone is following the workflow and using the software in a standard manner. Genetic counseling is a very autonomous position and practice. And so sometimes you need to circle them back in terms of, now remember, we're all using it this way so that you can really take advantage and optimize the flow of the department. Additional improvements since Cancer IQ went live, we now have our reports in our EMR. That has made a huge difference in terms of the very large care team that patients have between all the oncology specialists, navigators, even the cancer registry as far as going in and being able to abstract information for cancer registry reporting and follow-up is huge. We also implemented another module of Cerner. We're bringing on Cerner Ambulatory in many areas of the organization. Genetics was one of the first ones to come up on Cerner Ambulatory for appointment scheduling, and you can do some communication in that system as well to other providers. We also were able to implement a stat policy for our affected patient population. So patients that are diagnosed with cancer or have treatment decisions are designated as stats for us, and we will see them within 1 to 2 weeks for getting them in and getting a sample collected if they are appropriate for testing, and then fast-tracking them with the labs in terms of getting results back as quickly as possible. And then we recently implemented results as far as patients being referred to cancer genetics if they are high-risk breast. So those are the patients that were triple negative at age 60, diagnosed at age 60 or younger. And then there are also the patients with breast cancer diagnosed at age, regardless of their biomarkers, diagnosed at age 50 or younger. Those are our high-risk breasts that we really track. So we have implemented that on a breast dashboard, and that actually goes back to being physician-specific so that we can see if there's someone that needs additional information or education in terms of appropriate referrals to make sure that we are getting these patients into cancer genetics for risk assessment, since they are at very high risk. Our future goals and considerations include, our goal is paperless in 2020. So there's a lot of work going on in the program as far as preparing for that in terms of current records and cleanup, et cetera. And then, of course, increased program support and counseling staff. And you'll see the need in a moment as far as where that really comes home and how and the impact all of this has had. We want to look at use of some additional Cancer IQ modules. Right now we're using a specialty module since we are really focused on seeing patients that are truly filtered in terms of their risk, and we know that they should be evaluated. We're looking at screening and also expanded use of analytics programs. And then telegenetics, looking at using that technology to make it even easier for our patients who are challenged with travel from different areas of the county, and trying to make it as easy for them as possible to get their genetics consultation. We're also looking to expand to a third cancer center depending upon available staffing, and actually further integration with our EMR and Cancer IQ. And we also want to look at other situations of high-risk patients and include genetics referral integration into those dashboards. So I thought, in addition to looking at streamlining effects, one of the things is, with all the things to streamline, they come at a cost. And so how do you prove the value of genetics? Because it's not going to be return on investment from the consultation service alone. You have to look at a variety of other things and the impact genetics has on other aspects of patient care that have financial relevance as well as quality relevance. So one of the things that you can look at first is the downstream revenue from non-capitated patients. And as I said, I live in this managed care world, and so we're always differentiating between capitated patients, where every time you do an additional thing, it costs you, versus the non-capitated patients where you bring in revenue for additional services. So remember, I said I loved that particular guide that we have as far as impact on patient care management that we get from Cancer IQ. Well, you can take that information, and looking at the number of patients, you can look at increased screening frequencies if you've moved them into another level of screening, so they are now high risk, for example, in colonoscopy rather than a general colonoscopy code for screening. The other thing is, you may be replacing mammography with breast MRI if appropriate for a patient, and certainly the prophylactic surgeries. So this is just an example of some volumes that we saw for some of these downstream revenue things. I will caution you that it really makes a difference as far as your organization on whether or not those downstream revenues truly are yours. So for example, if you have a joint partnership with a radiology group for imaging, or some other thing that affects these particular streams, you have to make sure that you truly do own them and can count them in your downstream revenue. Another thing that we looked at was that staff efficiency. So you can look at, okay, if we've reduced that amount of time, those 2 hours per genetic counselor, and looking at their salary, what does that mean in terms of savings? You can calculate those savings, but you do not want to present that to a CFO to say, oh, look, we've got these savings, we can reduce staff. The fact is, there's so high a demand for genetic counseling that you really need to look at it in a new way, and that is, how many more patients can you see? So you want to increase or look at those additional patients so that you're satisfying as far as getting more patients in, meeting the need. You're also getting more downstream revenue from those patients, those additional patients that you're seeing, and you're also averting capital costs from future potential cancers for those patients. So we're going to go into that a little bit more, but there's 2 ways as far as revenue generation from downstream, but also cost avoidance when you look at being responsible for a population that is either managed or not managed if you're looking at it from a health plan standpoint. So averted or reduced costs, you're looking at, of course, when you've got a diagnostic workup and the treatment costs, et cetera, everything associated with a new cancer. And so those all become costs for a capped population. It also becomes a cost as you're looking at it from a health plan that they are paying out. The number of averted new primary care patients, if you look at it, many of these patients that are determined to be high risk actually have risk for multiple primaries coming after that first one. So breast cancer in particular, and we're doing some deep dives into that population to look at exactly how many additional primaries they had if they did not have that intervention of genetic counseling, prophylactic surgery, or at least close monitoring to pick it up early stage. And then as I just mentioned, even if you're not able to avert a cancer because it's not one of those cancers that you can remove, you can have a very high level of surveillance to pick them up earlier. And once you pick them up earlier, they will be less costly to treat. So here's an example. We took our breast cancer patients diagnosed in 2017. There are about 160 patients. So we looked at those that were triple negative, diagnosed at age 60 or younger, and any breast cancer diagnosed at age 50 or younger. So just looking at the hospital expense side of things that we could capture, not those patients that are treated in a private practice with chemo, et cetera. We looked at the average cost of a breast cancer, and what that meant to the health plans. When we looked at that and developed the algorithms and everything for what that meant, health plans, if they were all non-capped patients, so health plans were paying for every service, that means that if we could reduce a cancer, eliminate a cancer, one cancer for this population each, that would result in savings of $5.5 million. And remember, this is just 1 year net revenue to that plan. If we're looking at capped patients, and so we're only looking at the cost side of things, that's still $2.5 million in direct expense for this small population of patients that we've been able to avoid. Our population is mixed, so the end result is going to be in between, but that's something that you can look at within your own organization as far as the relevance for this. So when we looked at the same population, so what's the burden as far as the cost of breast panel testing and the counseling for this same population? It's less than $500,000. So that's a pretty good return on investment in terms of that counseling and avoided cost. So here is a summary as far as where we're kind of at today. So we've done these figures, and we're finding that the growth, we are way over the 7% going from 18 to 19, even year to date. So it's probably going to be another 20, 25% easily with what we're seeing. We still have patients that we're not seeing. And one of the things that happens is physicians will refer a patient, but they've really not had a good conversation as far as what to expect with that referral and what information is needed. They don't understand as far as what will be provided back, and some actually don't want to know if they're at increased risk. And then we still have a discrepancy in terms of reimbursement from health plans. So for example, because we're hospital-based and it's not a physician-based, for Medi-Cal or Medicaid patients, they actually are having to pay out of pocket for their counseling services, but their screening is, or their testing is covered. Medicare patients are the same. Medicare patients, they pay out of pocket for their counseling, but they may have their testing covered. Because we had so many patients that were coming in the door and not enough resources, we actually had to move 373 patients to from 2018 to 19 for scheduling, because we just didn't have enough slots for patient care in 2018. So we started the year off with 373 already impacting the schedule. So we saw a little over 800 patients. We had, with most of that time, we were still at 2.0 FTEs. We had not increased the staff time, so now we have 2.2. Big deal. Patients tested. This is a huge difference as far as 599 of those patients were tested. So 76.3% of our patients seen are tested because they're appropriate for testing. So that's a huge percentage in terms of the testing. And some of our physicians were questioning that high level of testing when we first began. And then as they saw the criteria and the filtering and everything else, they thought, oh, it's because all this work is kind of being done up front to make sure that they're appropriate. So just to give you an idea as far as what we're seeing, in 2018, of the 600 patients that were tested, 175 came back with a pathogenic mutation. That's 29% of the patients tested were positive. Now, the expected rate nationally, as far as the positive rate, if we had screening in there and that was blending it out, we would have expected 5 to 10% nationally. So this is truly getting at the right patients, you know, and that's why our testing figures are so high. Okay. And one more comment that I will have, and then it still takes us 2.5 hours per patient to prep them. And we spend about 30 minutes in review of the patient information to see if there's any questions that we need to ask or need to get information prior to their visit. We spend another 30 minutes in medical record review, and because we're kind of a fragmented system where we have to go out to multiple records, et cetera, then it takes that additional time to see path reports, et cetera, and try and garner additional information to put some of the patient information in context. Once we see the patient and we're generating our consultation report, that takes about 30 minutes for us to organize the information and input it, even using templates. Because again, we are so fragmented and don't have systems that are consistent for every provider throughout the system and how we do things, there's often a lot of communication coordination with the practice in terms of testing arrangements and information notification, sending reports to physicians that are not on our EMR, et cetera. And so that takes some time. And then another 30 minutes for generating the results and recommendations report. So with that, I think we can open up to questions. Jen, as far as allowing some of those to come in, or I think they're coming to you.
Absolutely. Thank you so much, Nancy. As I mentioned in previously, if you have any questions, you can send them through the question toolbar. Also, what I will do is I will unmute all the attendees. So please put yourself on mute if you don't plan on asking a question. And I will unmute everyone. So if you have any questions, you can go ahead and ask, or you can send through the toolbar. Otherwise, if you would prefer to send Nancy a question via email, her email can be found on the screen. And don't forget to include that number 2 after her last name, Harris, so it does not go to the incorrect Nancy Harris at Sharp, who also works there as well. All right, we have one question. And the first question is the administrative assistant vital to the program?
I'm not sure if you heard the first part, but
sorry about that, Nancy.
That's okay. Is the administrative assistant vital to the program? Absolutely vital. There's a variety of reasons. As I explained, they offload a lot of time that the genetics counselor was spending prior to bringing on the administrative assistant in just doing tasks that were unrelated to the expertise needed for genetic counseling. It's the coordination of the appointments, the information, and the communication with patients just to schedule and all of that, along with the health plans and coordination of authorizations. The other thing that it does is that you have genetics counselors that have been highly trained. They're very dedicated to their profession, and it's very unsatisfying from a professional standpoint.
Sorry about that, Nancy. I went ahead and just remuted everyone but you.
Got it. Okay. But it's really not professionally satisfying to a genetic counselor to be doing these tasks. And they're a very close-knit community, and they will seek out programs that have that level of support versus having to do everything themselves. So you're able to attract and retain genetics counselors by having this level of support as well.
So we have another question. Does Cancer IQ generate downstream activity utilization reports?
They can, and you'd have to talk with them more closely about that. As I mentioned, we are a system. All of our physicians are private practice physicians with the corporate practice of medicine law in California. They are not employed. They are not on the same system. They're not on the same EMR. So the ability to track and see what the downstream utilization is of breast MRI or the colonoscopies at the increased frequency, et cetera, that is something that we are challenged with because we do not have access to those EMRs. They're not all in the same EMR, so that you could gather that information with that integration. The best that we can do is looking at the patients that have come through our service and then looking at, okay, what are the services that were subsequent to their genetics counseling where they utilized a service that was within the hospital. For example, a prophylactic surgery would be a good example.
We had another question that came in. How many administrative assistants per genetic counselors would you recommend?
I think that depends upon the program. It also depends upon the administrative assistant. So a really high-performing one can do a great deal, and it really depends upon the logistics and and your systems and your processes. So I've had, and this is going back when it wasn't as explosive as far as all the information and everything going on. I had one administrative assistant that served 5 genetic counselors, but that was several years ago when it was much easier, and the authorization process was also much easier than it is today. Right now, for the 2.2 genetic counselors that I have one full-time administrative assistant, and recently we just increased hours for that second administrative support person to a 1.0. So it's almost a match depending upon the challenges of the program. And we have several with the managed care antics that we have to go through in this particular environment.
Next question is, how would a program manager benefit or not benefit from this program?
Don't quite understand the question as far as a program manager benefit from this program or not. We could get more information.
Yes, for the person, if you could submit some additional information about that, then we can try to get it to you. Otherwise, you can go ahead and email Nancy with further information about your question. The next question is a kind of a two-parter. Pre-cancer IQ, what was your patient volume per genetic counselor per week or year, whichever is easier to answer? Then post-cancer IQ, what was your patient volume per genetic counselor?
So pre-cancer IQ, our volume per patient, they could handle with having to spend 4.5 hours per patient, and then that's not including the patient visit. You know, at most, they could complete one patient, you know, in a day, and then maybe prep for another half in a day. So, I mean, it was half the volume that they could handle pre versus post. So was there a second part to that one?
The second part was the post.
Okay, got it.
I wanted to know the pre and post. And then another question that came in, the auto-completion function for test requisitions, is that something that comes from someone such as an administrative assistant having to still input the patient data?
It depends upon your system and how that can generate. So if Cancer IQ has all of the essential data, which most of it does live in Cancer IQ, for most of it, it can generate a lot of that information. And remember that there's also a lot of information in terms of the background of the patient that has to go into the test requisition. So for the most part, it can handle pretty much all of it. Because our genetic counselors are right there with the information, completing the testing, and there are so many pieces of that they need to do that's pretty easy to fill in the few parts that are missing that would have to manually be entered.
So we got a follow-up question to the one that needed more clarification. So what they were wanting to know is, would including a project manager in the staffing needs be necessary? Because it seems that tracking, report fetching, and monitoring would require one.
We don't have a project manager, and I think of a project manager as you have a project, you establish it, and then you move on to your next project if you're a project manager. So it may be a variation in terms of that definition. We did have a project manager for the implementation of Cancer IQ. I will tell you that our IT department came back and said, I think this is the easiest implementation we've probably ever done, because it was done so quickly, so smoothly, and it just worked out very well. But all the tracking and monitoring can easily be done by your administrative assistant or, you know, your administrative lead, because of the way things can be set up in Cancer IQ and the support that they provide as far as routine reports.
Great. Well, we are a few seconds away from the top of the hour, so if anyone has any unanswered questions, feel free to send Nancy an email, nancy.harris, Harris, the number 2, @sharp.com. Again, Nancy, thank you so much for providing this comprehensive webinar. It's been fantastic. And I hope everyone who is on the line has a fantastic rest of their day and a great weekend ahead.
Thank you very much, everyone.